Okay, so you know our group, the EU-MDS registry group from the ELN work package, MDS work package. We have been addressing the several issues in lower risk MDS. And I'm not going into the details of the organization, but so what you see here is what we have achieved in the last 40 years. So since we started in 14 years ago, so let's say, what you see here, most of you realize that we have started the registry in low risk MDS, and for that reason, the great majority of patients is now approaching 3,000 low risk MDS patients. And so we are also collecting the data in high-risk MDS and other types of myelodysplastic syndrome. Next slide. So the goal was for the question for today is, so are the classical features which we are using for defining diagnosis and prognosis and chance of responding. So we realized that several new parameters are not regularly assessed, and so one of these is the iron toxicity and oxidative stress issues, which are playing a role in the prognosis and the deterioration of MDS, low risk MDS. And so what you see here is a survival curves for during the first 4 years after diagnosis. And what you can see here is that the upper curve, these are patients who are transfusion independent, and also patients who have no labile plasma iron present in the blood, so they could not be detected. This is the upper curve, the blue line. And when you in the two curves here in the middle, the green line are patients who are transfusion independent but have labile plasma iron molecules. These are mainly patients who are SF3B1 positive or who have they have the iron overload in the specific cause. And in the lower curve, you see the patients who have both the iron transfusion dependent and have these labile plasma iron molecules. The same applies for the NTBI, and also for oxidative stress. I'm not going into the details, but this is just to show that. Next slide, please. To show that this is indeed very, very relevant. So patients who, low risk patients who have labile plasma iron detected, they have in 3 times more after adjustment, around 3 times more risk of dying earlier than the control group who do not have these labile plasma iron. And when you subdivide these patients in the 4 groups from which you saw at the survival curves, the reference group is the patients without toxic iron molecules, and you can see that these patients who are transfusion independent but have labile plasma iron molecules detectable have a 4 times more risk for premature deaths than the control group. And the same applies for patients who are transfusion dependent, either without labile plasma iron or and this is the worst group, who have who are transfusion dependent and who have these labile plasma iron molecules detectable in the blood. So this is information which has been published last year already, which we may consider to put this into our evaluation of the patients and diagnosis. So what you see here is the impact of red blood cell transfusions on outcome in the patients, and the main and we have defined the red blood cell transfusions as dose density. You may have seen that in the publication on this topic, and we looked at the impact of the dose density on the progression-free survival. And what you can see here is that there's a very steep incline of the log hazard ratio for progression-free survival, already below the 1 month one transfusion density per month. So you see this very steep incline, and it's gradually further increasing, but the increase here is not statistically significant. If you in the model, the multivariate model, you see the same increase very early at very low dosages of red blood cell transfusions per month. And when you adjust this for the interventions, which are usual in the low-risk MDS patients, which is ESA, iron chelation therapy, or lenalidomide, you see that the impact then is so the increase of the risk of lower progression-free survival is increasing over the range of 4 units per month dose density. So this means also that the transfusion, the negative impact of regular transfusion starts already at a very low dosage, lower than in the IPSS-R, for instance. This is another way of looking at the patient. So what is the reason of the cause of death in low-risk MDS? We know that most of the time it's MDS related. I'm not going into the details, but we also looked at the impact of the comparison of these patients with the general population who do not have MDS. So this is just a study on almost 3,000 low-risk patients nowadays. You see the MDS-related causes of death is 20 in this group of patients. Cardiovascular disease, infections, and other comorbidities are altogether providing around 40% of the cases, but 25% we do not know the causes of death in our patients. So the general 5 years overall survival is 47% at 5 years, but the relative survival in the control group is 59%. So that means that overall around 15% of the cases die from non-related causes. And especially older patients and the lowest risk patients are more likely to die from competing causes. That means causes not related to MDS. And here you see the causes of death. I'm not going into detail. The upper curves are the patients with other causes of death, and in the lower curves you see infections, cardiovascular, and so on. Next slide. When you look at the overall and the survival, the lower curve, and the relative survival for the control group, you see an overall difference of around 15%, which means that that 15% of the patients die from competing causes, competing with the MDS causes or MDS-related causes. So here is the definition of relative survival: the probability of surviving cancer in the absence of any other cause of death. Here you see the subdivision of the patients according to 3 age groups: the patients younger than 70, 70 to 79, and more than 80 years old. at the diagnosis. And you can see here that the oldest patient group, this curve, they have the largest difference with the for competing causes, which is you could have predicted that. So there's around 20% difference in these patients older than 80 years, sorry. When you look at the relative survival of the two curves, this is the dotted lines are the relative survival, and in the younger patients, that the two upper curves, you see the difference is much lower, which means that the great majority of these younger patients are not dying from competing causes. This is the difference in survival in the various subgroups. This was patients who were initially diagnosed as lower risk MDS, but they also contained the IPSS-R high-risk patients, and you can see that there's no difference in the relative survival and the high-risk patients, because all these patients die from MDS-related causes. And you can see gradually when you go up to the very low group, this is the upper two curves. You can see here, this is the largest difference. So these are the two intermediate risk groups. So this shows that there are several more factors which you may take into consideration when you look at the prognosis, diagnosis and prognosis of patients, and also when you start to consider interventions in these patients. So this was just a general limited contribution, because we also have patient-reported outcomes data, as suggested before. For instance, the quality of life data, they have also an impact on outcomes, so should be considered as well. Thank you.
Theo, it's Rena. Can I just clarify something? When you're talking about relative survival, I'm not exactly sure what I mean. This is not relative to age-matched controls, right? You're saying, meaning dying from a cause other than AML and MDS?
Yes, so the relative survival is a survival in a control group from the national, or from a group from the general population, the survival in this group who do not have MDS.
Ah, okay, so it is compared to age-matched controls. Okay, yeah. My second question is, you talked about other causes other than, you said cardiovascular infection, pulmonary infections as, other causes of death, but how can you say that these were not perhaps exacerbated by the presence of MDS, meaning, it was their poorly functioned neutrophils or thrombocytopenia and so forth that accelerate or the nature of having MDS by itself, and perhaps being a risk factor for cardiovascular disease and increased atherogenesis from clonal hematopoiesis. How do we know that those are not necessarily tied in with the MDS?
You sound like the tough reviewer, Rena.
Sorry, Moshe?
You sound like the tough reviewer who really gave us hard time about that question also.
I wasn't the reviewer. No, it's great. I mean,
I let you answer, and then maybe I'll add something about it.
So the definition of MDS-related factors is because we know, for instance, for cardiovascular diseases, that now we know that there's more inflammation which is caused by the MDS clone. There are several, but there are several reasons where patients with MDS die, for instance, by let's say liver problems or kidney problems and so on. So which are not caused by MDS-induced inflammatory factors or immune deficiencies influenced by the disease, which we call MDS, but also the pre-MDS groups have the same. So that means, but the general population, the control group, if you define this, they may have less deaths due to liver diseases than the MDS population. And this difference, you measure that by the relative survival.
I just want to add, Rena, that you're absolutely right. Sometimes it's extremely difficult to differentiate or distinguish and say this is the cause of death. But you got to realize, in addition to the objective difficulty, that this is real world data of a registry. So what we did basically, the attending physician on time had to decide or to determine what was the cause of death. And this is how we went according to. So it might be kind of overlapping because sometimes you don't know for sure whether the reason was pneumonia or MDS or cardiovascular or any combination, but it was according to the decision of the attending physician, and he or she were not aware of this kind of analysis.
Yeah, but you are right. But that's so. This is an attempt to come over these issues, as you both of you mentioned. You can imagine that, for instance, pneumonias in a patient who is 80 years of age. Also in the normal population, these patients die from pneumonia.
Mm-hmm.
The number of patients who die from pneumonia in the older population, MDS will be much higher. So, and that will yield more difference between the relative survival of the so-called normal age-matched population compared to the patients with MDS.
No, I don't disagree, and I think it's been shown using SEER data that the relative survival of MDS patients is by age or by risk score is worse. Mm-hmm. And I'm just not sure when you say competing causes. I mean, I would say their competing causes include MDS and all those other things, and whether or not we think that it's yeah, I guess maybe we're saying the same thing, that you're just saying they're having more cardiovascular disease, more respiratory infections, more, all those other complications. Whether or not we say it's directly or indirectly tied into their MDS, that's the way it fell out. And yeah.
Yeah, and especially the group of patients who die, low risk MDS patients and older patients who die at home or in a community setting, they die from an unknown reason. So there's no real diagnosis, yeah. And that may occur more often in this group of patients without MDS in the normal population compared to the MDS patients.
Mm-hmm. Mm-hmm. I mean, as you know, it would be very helpful if we were to have had availability of frailty information on these patients to show that, any given MDS patient, we know that frailty adds about 25 to 30% of the prognostic ability for survival.
Mm-hmm. Yeah.
We don't have the frailty, but we have quality of data.
Hey everybody, this is Mikkael. Very nice presentation, Theo. And I kind of zeroed in on the same issue as Dr. Buckstein, and I promise I was not one of your reviewers either. So it sounds like what you're saying is whether or not a death was related to MDS was determined by the treating physician, and that was entered as a field in the data that were filled out about the patient. Is that correct?
Mm-hmm. Yes.
So, it's extremely challenging to figure out if somebody's death was due directly to their MDS or even indirectly or far indirectly, right? And you've all kind of talked about different scenarios where that may be the case. For example, somebody who's heavily blood transfusion dependent may develop congestive heart failure and die from congestive heart failure, and that was the cause of death, but it was indirectly related to the transfusion needs for the MDS. So I have a couple of thoughts about this. The first is to ask whether, in somebody who died of pneumonia, was there an attempt to look at that person's neutrophil count and say that it's more likely, you can identify a higher likelihood of the pneumonia being related to MDS if their neutrophil count was less than 1,000 than if it was greater than 1,000, for example. Or if the person died of a bleeding event and their platelets were less than 50,000 versus greater than 50,000, you can assign a higher likelihood of death being related to MDS. My second comment about this isn't the only area of medicine where there's challenges in trying to identify causality. So, for example, the Infectious Disease Society of America, the IDSA, assigns relative certainty with somebody having a fungal infection. So it's either a definite fungal infection, biopsy proven, probable based on classic CT findings, possible based on a chest X-ray finding, etc. I wonder if there's a way that we could do that also with some of the MDS patients in this database, given that self-reporting by a physician who's treating the patient is probably going to be inaccurate.
Yeah, but here the last slide, which is still on the screen, at least in my you can see that all what you're saying is correct, but you can see that if you compare the highest risk group with the relative survival in the general population, you see that the survival is overlapping. So that means that the great majority of these patients are dying due to the disease related. So related to the disease, whether they have neutropenia or whether they have let's say transfusions, or they have a poor quality of life. So it's dominant. The disease is dominant and determinant when you compare it to the general age-matched population.
Yeah, I see that. I was just wondering if we could, to say that something is MDS related versus not MDS related is very challenging. So I wonder if there's a way we could introduce something to increase the likelihood that it's actually MDS related based on the blood counts that a patient has.
The main author, the scientific author, is in our audience, Alex. So can you help us?
Yeah, I think Michael's asking a different question, saying, is there any way you can actually say, looking at the parameters, that that patient did die of their MDS? Is you trying to think of, not like a prognostic score as such, but something that actually says, yes, they probably did die of their MDS because of their blood count parameters or something like that. So I'm not clinical. I did these analyses, and that's one of the reasons we use relative survival, and it was developed by cancer registries, because often, as you say, it's very hard to determine the cause of death. So they used it to looking at life tables, so what you'd expect for that patient with their age and sex. And as you can see, the red line showing patients with very high IPSS score, and because the lines overline the dotted line and the solid line overline, it's shown that once you take into the background mortality, most patients with very high IPSS are dying from the disease, but in contrast, those with very low, there's a gap between the solid blue line and the dotted blue line. So most patients who are dying with very low IPSS are dying from other competing causes. And that's the only thing you can do with relative survival. I'm not sure how easy it would be to develop a tool to say a patient's definitely dying from their MDS.
I don't think it would be that. I mean, you have an incredible registry. I don't think it would be that difficult to identify patients who died of pneumonia and then look at the subset of those who had a low white count and say, these are probable deaths from MDS. These may be less likely deaths from MDS.
I think you're right. I think we can still go back. Maybe we haven't done it in this analysis, but we can go back and compare or relate the initial white blood cell count as opposed to the cause of death. I think this is feasible. We have to talk about it. We haven't done it, but I think, Theo, Alex, we should maybe reconsider it. I think it makes sense.
It just gives an opportunity if you're going to, because this is an incredibly interesting area of MDS, looking at competing causes of death, given the age of these folks versus something that's directly related to MDS. So you could even establish a standard of how you would predict causality of death moving forward for other MDS studies. because you have the data. Yeah, and very few places in the world have these kind of data.
I'm a little puzzled though. If you're for the high and very high risk group, if you're just comparing their survival with age and sex match controls without MDS, am I correct? That's what that curve is showing?
Just about, it's life tables. So you're looking at what you'd expect for the country. So like, you know, for insurance and when they make predictions about how long someone's going to live, they use life tables. Yeah. So we're looking at the country as a whole.
Okay, like the actuarial survival of someone who's 80,
right.
With or without high or very high risk disease.
Yeah.
Why is it so close? Why are those two curves so close? Because it's not like we expect everyone to be in high and very high risk to be, you know, more aged or more frail or have more comorbidities than somebody, for example, with intermediate risk disease. I'm just a little surprised that there's not a bigger difference in those curves. Is that just because you just have fewer patients in your registry with high and very high risk disease?
Yes, and because before 2017, all the patients had lower risk disease. So actually those ones with higher risk are probably a certain type of patients that we've reclassified as well. So I think if you looked in a MDS registry, if we look now we've been ascertaining higher risk patients for the last couple of years, maybe you'll see something else slightly different. So, and I presume these patients are the ones that transform to AML or higher risk MDS relatively quickly as well.
Yeah, so that's why I would have thought there would be a bigger difference between those the dotted line and the red line, not so close together.
So, yeah, I think the high and very high is based on small numbers, so we probably want to look that in a bit. Now we've got more patients in those categories, so we probably need to relook at it.
Okay, thank you for this stimulating discussion, Alex. So you have covered this, I suppose, clearly, but do you really think that in the future, when we have more high-risk patients who are available in this way, will change?
Just I wonder now the patients that with high and very high risk IPSS are more representative third patients, whereas because this group here we reclassified from IPSS score and the original eligibility criteria. So I don't know. And I think when we looked at it before, we had a feeling that there was they're perhaps not representative of all high and very high risk patients because of the classification, this criteria they had to reach to be in the registry. So it's probably worth looking.
Theo, does the registry, the low risk MDS registry, capture comorbidity? I know you have EQ5D.
Yeah.
So it could be a real interesting reanalysis just according to comorbidity to see how these curves, if they look different.
Okay, thank you. The two other topics, the transfusion density, the impact on outcome, and the toxic iron molecules. So any comments on these two?
How easy is it to measure LPI, and you know, how readily available, how expensive a test is it, and you know, could there be a surrogate for LPI? You know, we recently published a paper last year in Hematologica looking at the impact of iron saturation and showing that there was a big threshold at 85% for predicting survival, and that we could, you know, further prognosticate in those patients with elevated ferritin by the iron saturation. Because I don't know that LPI is going to be, I think it's very compelling and I believe it. I do believe in it, but I don't know how readily accessible LPI is as a test. Yeah,
that you are completely correct. So we used one of these methods which were available, let's say, until 3 or 4 years ago. But the company who was doing it, they have stopped doing it, so it's not readily available. And there are different methods to measure LPI. For NTBI, it's much cheaper and it's more readily available. And you are right, transferrin saturation. I didn't show the data, but it is also prognostic. but my main message was that it probably makes sense to evaluate the patients, and especially the patients who have a high risk, like the ring sideroblastic anemia patients and the patients with high hepcidin levels and so on. SF3B1, of course, also. So it makes sense to at least try to have this information. Transfusion saturation should be available in every county and every treating hospital.
Mm-hmm.
But
I've started to use it as well in terms of deciding on, I have a patient with a ferritin of 1500, but their iron saturation is 25%. Historically, I used to start them on iron chelation if they were transfusion dependent, but now I'm sort of waiting a little bit to see when their iron saturation starts to go up. Because I think we have a lot of uncertainty in when to start iron chelation therapy, which is toxic for a lot of our patients.
Okay, shall we continue?